Good afternoon, Shlomit.
Hi, how are you?
I'm good. Let me see if I can put my camera on. Let's see. Oh, let me, just a few seconds. It tells me to restart Zoom for the camera.
Okay.
I'll be back in a few seconds.
Okay.
So that is me.
Hi.
Hi, good afternoon.
Good afternoon. How are you?
I am good. And how is yourself?
Fine.
Good.
Yes,
So,
we will wait because we have a few people that registered, like 55. So I hope they all will enter. And then I'll speak in Hebrew for a few words, and then you will start.
Good.
And at the end, I'll speak again in Hebrew.
Yeah, and I'll be talking for roughly 45 minutes.
Yes, and then 15 minutes for questions.
Q&A.
Yes.
Yeah, and I understood from my colleague that if I were to do this entire presentation in Dutch, then that would be okay too.
No, in English. We
Sorry,
don't know Dutch.
Just kidding.
There is one that registered that she's from Holland.
Yeah, I like her already.
Yes, she's from Holland.
Immediately,
I don't know if she will come, but...
Well, if she's Dutch and she knows me, then definitely she'll be there. So I'll just follow your lead and I will start when you tell me to start.
הנה מיכל,
היי.
הם רואים אותנו?
Yes. מה נשמע?
בסדר, מה נשמע?
איזה יפים אתם שניכם.
תודה.
את רואה את ניינס ונדר כבר?
אתה רוצה... מה?
לא, אני אקשיב בצד, מעניין אותי אחר כך.
תקשיב בצד.
טוב. בואי אני אעשה לך מקום.
הנה, נכנסו כבר יש עוד אנשים שמצטרפים. רגע. I need to do him co-host. איך אני עושה את זה? New profile. Just a second. No, yes.
And do you have the system set up in such a way that when there's noise from people participating, that the audio and video doesn't automatically go to that person?
I don't know.
Well, let's see.
What's the no one? What is it? Host and co-host? Where are you? Host and co-host. This is me. Where are you? View. Speaker. Can you try to share your screen?
I am about to.
למה אני לא רואה? אנשים. רגע, מה עשיתי פה, אלוהים?
Let's see. Let's see if this is the right one.
Here. Yeah, now I can see them. Okay. So now.
And you don't have any pictures yet.
Host, that's you. Make host. Now you are the host.
I see.
Yes.
But it's still not sharing.
You have to do in the bottom, share screen.
Yeah, I know that. But it, again, because I had to change the settings,
Okay. What is
that
this?
it tells me to log out and log in again. And so if now I'm the host, then I
רגע, so
can't
I'll
log
take the
out.
host just a second.
Please.
רגע, איך אני reclaim host. Yes, you're the host.
Okay.
Now you go out and in again, and then I'll give you the host again. Great. We are starting in a few minutes.
שלום שלומית.
היי, מה נשמע?
בסדר, בסדר, מה נשמע?
בסדר, הנה אני רואה פה את נייס. make host. yes, yes. יופי.
יופי. בטח שעה קצת מאתגרת לחלק מהאימהות.
כן, נו, מה אני אעשה? יש
אוקיי.
אילוצים, את יודעת.
האילוצים הם חיינו.
נייס, you are here?
I am. Can you
I
hear
can't
me?
see you, but you are the host now. So we have 17 logged in. Let's wait for 3 more minutes and then we will start, okay? Because we promised to start at time. I can see you now. Now you can share screen.
I am. Let me just give it a few seconds.
Okay.
היום ויתרת על חדר כושר, נכון?
יש פה הובלת חלב, נכון?
לא בטוחה, עושים הרבה פעמים פרווה, צריך לקרוא מה כתוב על זה. עם פרווה או חלבי.
Just give me 2 seconds, Shlomi. I'll just
Okay.
need to confirm with my colleague.
Okay.
אני רוצה, ההנחה היא בדרך כלל שזה פרווה, תמיד הם כותבים, אין מצב שהם לא כתבו. צמחים, מידע, קודם כל עם המידע כאן לא כתוב חלב, כאן לפי גלוטן, חיטה, ביצים.
חלב, חלב. לא יותר
איפה?
חיטה, חלב, ביצים.
זה אייפון 4.
חלב? כן.
וואי, אני רוצה אבל לאכול את זה כל כך.
מי שהוסט יכול להשמיך את כולם, אז את יכולה לעשות את זה, שלומית.
כן, אבל אני כבר לא ההוסט, נתתי לו את ההוסט. אז אני יכולה לקחת את ההוסט ולהחזיר לו? רגע, ואני אשנמך. mute. ask to mute. ask to mute. יופי, נו. זהו, הנמכתי את כולם? mute all. mute all, yes. יופי. עכשיו, איפה ניילס? עכשיו הוא יהיה ההוסט. יופי. make host. יאללה. ניילס?
I am here.
יופי.
And have you got?
Let's start because it's 5:05 and I want to start. So can you, I want to speak in Hebrew for a while and then you will start, okay?
Yes, but I'm still having issues with the screen. This is ridiculous.
You want to send it to me?
I can't in such a short notice.
Can you log from your phone and then maybe share it?
Let's see what I can do.
אוקיי. ובינתיים אני אדבר בעברית. Niles?
Sorry, yes.
Can I start speaking Hebrew? Or...
Yes, of course you can.
Okay.
Of course.
So, ברוכים הבאים everybody. היי לכולם, ברוכים הבאים. אני שלומית מ-MYOFunctional ישראל, שהיא חלק מקבוצת סילמט, שזו חברה שמתמחה בייצור ושיווק של מוצרים דנטליים ואורתודונטים, ואנחנו החלטנו כהחלטה אסטרטגית של החברה, להתחיל לעזור לטפל בילדים בגיל המוקדם ובתחום של תפקודי הפה, גם למבוגרים כמובן, אבל גם לילדים. כקלינאיות תקשורת, לכם יש את הניסיון עם הטיפול בילדים, אך עדיין בארץ יש כאילו המון מידע והמון דברים שאתם עושות, אבל פחות קצת בתפקודי הפה. ואנחנו, המטרה שלנו באמת לקדם את הנושא של תפקודי הפה, לאתר בעיות שפתיות, התפתחותיות, וכבר בגיל הצעיר. ואנחנו מציעים מגוון של אביזרים שעוזרים לטפל, זאת אומרת, הם באמת עוזרים לקדם את הטיפול, אוקיי? מה שאתם מכירות עד היום. אתם תשמעו גם כמובן את ההרצאה של ניילס. הוא מ-MRC, שזה MYOFunctional Research Company. זאת חברה בינלאומית, מובילה בתחום, היא פועלת מעל 30 שנה באירופה, ארצות הברית, באירופה וארצות הברית ואוסטרליה, והחברה מציעה 150 סטדים שונים וטריינרים שונים, והיא מבצעת מחקר ופיתוח, ויש להם תוכניות תרגול, גם אפליקציות, גם אתרים שעוזרים עם התרגול של המוצרים. את המוצרים שלנו ניתן למצוא כמובן בחנות אונליין שלנו, שבסוף אני אשלח לכם לינק, מי שתרצה. ויש לנו כמובן אתר מידע שהוא MYOFunctional Israel, שאני גם אשלח לכם לינק אליו. זהו, אנחנו תכף ניתן לניילס להתחיל ולדבר. כל שאלה, כל בקשה, אני ארשום לכם גם את המייל שלי ואת הנייד שלי, תוכלו לפנות אליי, ובסוף הזום תהיה לכם הטבה רק להיום של רכישה של 1+1 למוצרים. וזהו, אני שמחה להציג את ניילס ונדרוולק, הוא יועץ הדרכה של חברת MRC באירופה. ניילס?
Yes, I'm here, and I have just one request. Can you make yourself host again?
Yes.
And then I'll be gone for 10 seconds.
Okay, I am the host.
And then I can share.
Okay, I am the host. מישהו יש לו שאלה עד עכשיו? משהו שהוא רוצה לדעת? בינתיים?
את רוצה להגיד לנו רק אם ניילס הוא קלינאי תקשורת?
תכף הוא יגיד, הוא יספר על עצמו.
אוקיי.
הנה הוא. יופי. ניילס? No, it's not me. It's him. Yay.
Can you hear me?
Yes.
Yes. And do you have a screen now?
Yes, I can see your screen, but I can't see everybody else.
You can't see everybody else. Would you like to?
Yes.
No, because you've made me host now to share the screen.
Yes.
And so that
okay.
makes it
So,
that makes it
כולם
difficult
שומעים
for you.
אותנו? אפשר להתחיל? Guys?
כן, שומעים.
יופי. Nice, you can start. Start by
Good.
introducing yourself, okay?
Yes.
Great.
And so, hi everyone. I'm Niels. I'm from MYOFunctional Research Company, and you'll see me here with a bit of a bigger beard than I have right now. And so over the years, it just keeps getting smaller and smaller. But I've been working for the company for 12 years now. And in those 12 years, I've been working with functional specialists, dental professionals as well. And I support practices when they treat functional issues. And so I work closely with orthodontists, dentists, and speech-language therapists such as yourself. And I help them set up entire training programs in their practice. And so I'm here to introduce to you our view on myofunctional problems and how to treat those. But in general, our company has one mission since we began 40 years ago. And our mission is to develop simple and innovative appliance systems and educational programs for health practitioners such as yourself. And we treat what we call functional problems. We treat incorrect swallowing patterns, incorrect breathing patterns that are the base for malocclusion, TMJ problems, and breathing-related sleep disorders. And so I reckon that you are well aware with those problems and how to treat them. We hope that our treatment systems help you support your therapy. But we have multiple treatment systems. Perhaps most of you will know our treatment systems. We have, for example, our MyoBrace system. That is a treatment system, what we call myofunctional orthodontics. And we have MYOSA as a treatment system to support allied health professionals. And
I can't hear. Niles? Niles? Niles?
Introduced. That is a treatment system that we have introduced 25 years ago, but now it has evolved into a MYOSA treatment system. And so we'll go on about our appliances in a short while. But firstly, what it is that we do, that we focus on the functional problems that we see with malocclusion. So with every type of crooked teeth, there is a functional problem as well. So either when we're talking about children, so either a child with crooked teeth has an incorrect swallowing pattern
Niles,
or an incorrect breathing pattern. Yes.
We can't see your presentation. It's not moving.
Hey.
We see only the first slide.
Let's see what image
now
do
we
you
can
have
see
now?
The 125 years of orthodontics.
Yeah, good.
Okay.
I'll see what I'll keep it in mind what you are able to see.
Okay.
We focus on the functional problems, and it is not new what we do. My boss, an Australian orthodontist, started 40 years ago with treatment system to support dentists and allied health professionals in their treatments and therapies. But more than 100 years ago, this was already a discussion. And so I don't know if you are familiar with the premise of function and form. So function follows form and form follows function. But more than 100 years ago, what you see here are the founding fathers of modern day orthodontics. They were already talking about functional problems. So let me just pick one, that is Dr. Angle. That is probably a well-known orthodontist to most of you. He came up with the Angle classification of malocclusion. So if you're talking about a class 1 or a class 2 or class 3 malocclusion, this is the doctor that came up with it first. But he was already talking about the tongue being the best orthodontic appliance that you can have. But more than 100 years ago, he didn't have a clue how to harness the power of the tongue. And so now, luckily, more than 100 years later, we have so many, we have thought up of so many treatments and therapies to be able to actually harness the tongue. And perhaps you are well aware that the tongue is responsible for craniofacial development. For more than half of the craniofacial growth that comes from the development of an upper jaw comes from the tongue. And so we can rearrange teeth with braces, with whatever orthodontic technique you would like to use. Just straightening the teeth is only part of the solution, because the problem also includes functional problems, such as incorrect swallowing, incorrect breathing. And so we as practitioners, we need to do more than just straightening the teeth. And that is where you come in, the functional specialist, the speech language therapists, the myofunctional therapists, because you have a way of correcting incorrect swallowing and incorrect breathing patterns. And so let me go over to the next. I will show you a video, and after the video, we'll pick it up.
It's not moving. The video is not moving.
And I'll see what I can do with that.
You have to share the screen in a different way.
Yeah, let me just do it this way.
Okay.
Here we go.
Everybody can see, yes. אמורים לשמוע משהו? Niles? We have to hear it?
Yes.
We can't hear it. We can only see.
You can.
You have to share also the audio.
I know. And it should.
Effect on jaw growth. Untreated.
Now.
That was good audio. Thank you.
Yes.
Every system in your body relies on oxygen, making breathing an essential function for life. Your nose is perfectly optimized for breathing as it warms, humidifies, and purifies the air you breathe. During nasal breathing, the lip muscles are sealed and relaxed. The tongue rests against the palate, and this creates a normal swallowing pattern. The upper jaw is developed by the tongue, and the correctly functioning lip and cheek muscles keep the teeth aligned. During mouth breathing, the lips open, the tongue descends from the palate, the cheeks push the teeth in, and an incorrect swallowing pattern emerges, which all combine to restrict jaw growth and crowd the teeth. The incorrect swallowing pattern pushes the lower jaw backwards repeatedly, causing dysfunction in the temporomandibular joints, or TMJ, and potentially causing long-term damage. Changes in jaw and head posture result as compensation, leading to tension and inflammation in the head, neck, and back muscles. The resulting symptoms are diverse and may lead to clicking in the joints, as well as aches and pain in the head, neck, and back. This problem is known as TMJ disorder, and when left untreated, progressively gets worse over time. Mouth breathing is medically recognized as a form of sleep-related breathing disorder, or SRBD. With its restrictive effect on jaw growth, untreated mouth breathing acts to further reduce airway space over time and worsen the SRBD. The severest form of SRBD is known as obstructive sleep apnea, or OSA. This is where the tongue falls into the throat and the airway muscles lose their strength, resulting in collapse and obstruction of the airway. Sufferers can wake up multiple times per night and have an increased risk of cardiovascular problems like heart attacks and stroke. TMJ and breathing disorders are interrelated chronic health problems that affect countless people worldwide, many of whom continue to suffer undiagnosed and untreated. Traditional approaches to TMJ and airway issues only address the symptoms, while doing little to treat the underlying contributors. Speak to your health practitioner about how to achieve the best and most stable results for breathing and TMJ disorder.
And so this video emphasizes the connection between incorrect function and problems later on in life, and even medically problematic issues later on in life. I reckon that you have all heard of an obstructive sleep apnea, because we identify two functional problems as the cause of malocclusion, TMJ issues, and sleep-related breathing disorders, such as obstructive sleep apnea. And this video tells you exactly that, and where I come from, how I approach the problem with regards to patients and parents, is that whatever therapy that you offer needs to be a solution to a problem that they understand. If parents and patients don't understand the problem, then they will never see a solution in your therapy, whether you use one of our appliances to support your treatment or not. And so it is really important that you understand the problem yourself. And so from the two functional issues, such as incorrect swallowing and breathing, we take mouth breathing as the most important problem that you need to treat first. Because what happens, why mouth breathing is medically so problematic, is that when you breathe through your mouth, there is not enough oxygen to work in your body. And that is due to carbon dioxide. And after this presentation, you will receive this information and this slide as well. Can you see the slide?
Yes.
Good. This is what happens when you breathe through your mouth. With breathing, we need carbon dioxide to get oxygen to work in our body. Each and every time that we inhale, we take in a lot of oxygen. And so there is no shortage of oxygen. But we do need carbon dioxide to get oxygen to work in our body. But when we breathe through our mouths, we exhale too much carbon dioxide. and therefore we see a low oxygenation of our blood cells. And what happens then is that your body is trying to solve that problem. And we see heart rate going up to get more oxygen to the parts of your body. But when your heart rate goes up, your stress hormone gets produced more. And so your body is in a fight or flight situation. And that fight and flight situation, even during sleep, that counts for a lot of problem in children. And you'll see right down here, when we're talking about sleep disordered breathing, because that low oxygenation during sleep is actually getting worse and worse. And so what happens to children with sleep disordered breathing is that they have a really poor quality of sleep. And poor quality sleep leads to learning difficulties, behavioral problems, daytime sleepiness, even bedwetting. And so it's not just the mouth breathing that is problematic, but the symptoms of sleep disordered breathing, that is what they encounter, that is what they experience each and every day. And so now we're not talking about open mouth posture, just that. No, we're talking about children who have problem concentrating at school, who have behavioral issues because of the chronic tiredness. Because with sleep disordered breathing, you do not follow a regular sleep cycle. And in adults, the problem is the same, but we tend to focus on children mainly because with children, we can actually solve the problem. In adults, in theory, we can solve the problem also, but it is way more difficult with adults. And so we focus mainly on children, but these are all problems that they encounter, and the parents as well, that they encounter every day. And so it is important for you to understand what mouth breathing leads to. And when you are breathing through your mouth, your breathing rate is too high. You take too many breaths per minute. You are hyperventilating. So that is not healthy. And then your mouth is not made to breathe through. Your mouth has no filters, while your nose has all the filters. And so you have an increased susceptibility to infections, to allergies, asthma symptoms. And this is where the form follows function and function follows form comes into play. When you have your mouth open to breathe through your mouth, you have a low tongue resting position. But we need the tongue to develop the upper arch. When we're not eating, drinking, or talking, your tongue should rest up against the palate. Each and every time you swallow, the tongue shows its biceps and directs the growth of an upper jaw. And so when we're talking about open mouth posture in children, that tongue does not take care of the development of an upper jaw, with malocclusion as a result. And so it's not that mouth breathing or an incorrect swallowing pattern always develops the same malocclusion, but we can tell by the malocclusion if we're dealing with incorrect swallowing or incorrect breathing. And so you just name a malocclusion and we can define the functional problems. And so it is really important for you functional specialists to address these problems, preferably at a young age, to prevent worse later on in life. And so this is what we're talking about. The blueprint for growth of bone lies in muscles, tongue, lips, and cheeks. We don't control growth of bone, but the direction of growth is determined by the muscles surrounding the bone. And so that is why when you see children with an incorrect swallowing pattern, that normal profile development does not take place. We can tell by a child's profile whether an upper jaw or a lower jaw is underdeveloped. And so we need to treat the functional problems as soon as we see them. And so there's a really big difference between the speech language therapists and the myofunctional therapists and the dental professionals, and especially the orthodontists, because the orthodontists, they can only do whatever they would like to do when the child is so much more older. And so we can treat crooked teeth when there's no growth left anymore. And so now when you're looking at a 6-year-old with already a narrow upper arch and crowding and whatever malocclusion, to just look at the teeth, the malocclusion as the problem, that is when we have to tell that 6-year-old to come back in another 6 years. And so just treating the teeth is not enough. We need to treat the functional problem, because this is what we're talking about. Teeth will move when we apply pressure. A tooth moves with the when we apply pressure of 1.7 grams per square centimeter. That's not much. If, in case of an incorrect swallowing pattern, the lower lip and the chin muscle, they exert a force of 100 to 300 grams per square centimeter of force. And so when you're looking at a child with an incorrect swallowing pattern, the crooked lower teeth become really obvious. You know why the teeth are crooked? Because you swallow on average, you swallow 2,000 times a day. And so 2,000 times a day, that chin muscle is active, pushing back on those lower anterior teeth. And so they do not get the chance to grow straight. And so the tongue is considered the strongest group of muscles in your body. And it is capable of so much, as long as it's in its proper place. But now when we're talking about a mouth-breathing child with a low tongue resting position, that tongue does so much, but not the correct way. And so I'll show you this slide. When we look at the child on the right, you can tell by her profile that normal growth and development did not take place. And as a functional specialist, I think that you can see what her functional issues are. She has both a mouth breathing problem, because you can see that her lips are apart. She has a mouth open, and when you have your mouth open, you automatically start to breathe through your mouth. And so now we know that her tongue position at rest is incorrect. So we now know that her upper jaw does not develop properly. And we see that her lower jaw has not taken the proper forward position that it needs to be in. And so you can see that a big part of her profile is missing. But this is not a case of a lower jaw not growing properly, because bone growth still occurs. We have no control over that. But the lower jaw has not come into that forward position because it's being pushed back by the muscle. And so everybody can still hear me, right?
Yeah, can you shut everyone, because you're the host? Mute all.
Let's see. It should have been. Let's see. There you are.
That's the. Can you elaborate on your profession and what is your education? Because I got asked on the chat, and what is your specialty?
What my specialty is? That's a really good one. Shall I show myself as well? So here I am. I'm actually what you call a I am well experienced in whatever happens if you do not treat these functional issues. I have a pharmaceutical background, but I came into contact with practitioners 50 years ago when I was diagnosed with an obstructive sleep apnea. And as an adult, I've had 6 years of fixed orthodontics. And so I was dealing with a lot of problems that we've just spoken about. And one of the practitioners, a specialist, a TMJ specialist, has told me that whatever I did with the orthodontist with regards to my malocclusion and my obstructive sleep apnea, that would never be a solution. So that kind of got me thinking, and then I was introduced to my functional research company, and it's like one big puzzle that everything fell into place, that every case that I see and that I present in my lectures with regards to mouth breathing with a typical mouth breathing profile, that was me when I was young. And now, so many years later, I can actually see whatever happened to me in my early years, that has been the cause of all the issues that I encounter as an adult. And so the first idea I got when I was taught how to treat this is, the first idea I had was, why doesn't anyone talk about this? This is something that needs to be taught. This is something that everybody needs to understand, that orthodontics is great, and cosmetically as well, because we love the Hollywood smile, don't we? But it's not a solution. And now, just by looking at children and just evaluating the problems, you can see so much. And so that is why what I've been doing in the past 12 years is that I've been supporting practices to treat young children and adults when it comes to functional problems. And so that is me in short. Would that answer the question?
Anyone else wants to ask? Let's go on.
Good. After the lecture, you will also be given an evaluation form. And have you got the evaluation slide now?
We can see it, yes.
Yeah, good.
Yes.
And this evaluation form, this connects the functional problem with the malocclusion, because they go hand in hand. And it doesn't matter which one was there first. It's like the chicken and the egg, which was there first. But with every functional problem, there is a malocclusion. And with every malocclusion, there is a functional problem. And so before you start your treatment, before you start your therapy, it is wise to evaluate both. And our evaluation form will allow you to do that. And so you do evaluate on malocclusion. So we do look at upper jaw, lower jaw. How are the teeth? Are they crowded? Are we talking about a class 2 situation? Do we have an overbite, an overjet? You name it. But you need to evaluate it properly, because you do use this evaluation form further along in treatment to measure progress. That is really important. And next to the malocclusion, we also evaluate on function. And so now we're talking about breathing and posture, about tongue position, about swallowing, lips and cheeks. You as functional specialists, you know well what to look for. And this evaluation form is just a handy tool for you to combine all your findings. There is a part of the evaluation form which says MYOSA screening. MYOSA is the treatment system for allied health professionals. The MYOSA screening part of the evaluation is
the tests.
The tests, really good. And we look at the breathing because of our treatment goals, and I will talk about that in just a minute. But we have treatment goal number 1 is nasal breathing. if we do not establish nasal breathing, then all the other treatment goals will never come into play. So we need to address the mouth breathing first. But we have mouth breathing and we have mouth breathing. Some children have such a strong mouth breathing problem that we simply cannot ask them to close their lips and breathe through their nose, because it's just too difficult, because that mouth breathing problem is so severe that they need some special attention to get that mouth breathing turned into nasal breathing. And so we have a few tests.
Yes. Niles? מה קורה? Anyone?
Breathe through their nose for 3 minutes. And you have a possible 3 outcomes. 1, they manage, they can actually use their nose for 3 minutes. Then you know mouth breathing is a problem, but it does not stand in the way of improvement. And so you can just start your treatment and use MYOSA appliances to support your treatment. The second outcome is that they cannot breathe through their nose for 3 minutes. During the 3 minutes, they will open their mouth and start to breathe through their mouth because they simply cannot do it. Then you know this is going to be an issue. We need to pay some extra attention to that mouth breathing problem. Third outcome is that they can breathe through the nose for 3 minutes, but with a lot of difficulty. And I have a video here that will show you just that. This is a boy that we simply asked to breathe through his nose for 3 minutes. And if you can watch him comfortably, then I applaud you, because I still can't, and I've been using this video for years. I actually feel his struggle. He is trying to breathe through his nose. His nose is accessible, but now his brain has to deal with carbon dioxide levels that it's not used to. And so this is the struggle that we see with children with a severe mouth breathing problem. And I can tell that most of you, perhaps all of you, will know this feeling. I reckon you've all experienced this feeling. And this is when carbon dioxide levels in your body rise, your brain needs to be able to cope with that. And so when you go to the gym, when you go for a run outside, you burn energy. But as a byproduct of burning energy, you produce carbon dioxide. And so when you exert yourself, there will come, you will get to that point where you start to open your mouth and start to pant away. And that is your brain's reaction to carbon dioxide levels rising and rising. Your brain panics. And so when you go out for a run and you come to that point where you need to open your mouth and start to pant, that reaction is what we see here with this boy. But this is not a normal situation because he didn't exert himself. He's just breathing through his nose. But his brain is already telling him to throw away a lot of carbon dioxide. And so this is something that we need to tell the children, we need to teach the children that a normal way of breathing, nasal breathing, is actually normal. And so we use the tests as exercise as well. And so what our treatment goals are to correct the functional problems, incorrect swallowing and incorrect breathing, we have 4 treatment goals for every treatment system that we have, whether it is myofunctional orthodontic treatment, whether it is to support myofunctional therapy, doesn't matter. We have the same 4 treatment goals. And so goal number 1 is establish nasal breathing. If we cannot get the child to breathe through the nose, then we can forget about all the other treatment goals. So when we've established nasal breathing, then we focus on correcting the tongue resting position. When we're not eating, drinking, or talking, the tongue should rest up against the palate. Next treatment goal is correct swallowing, so without the use of supporting muscles. And final goal is correct lip posture. We do talk about correct diet, so we do need children to chew their food properly and to swallow properly as well, but healthy foods. And so we do not cut the crusts of bread. We do not boil every vegetable that we have down to a pulp. No, children need to chew. So we need to get those chewing muscles working again as well. And so in the end, when you have corrected the function, then normal growth and development will take place. And then there is no need for teeth to come in crooked. And so now I will show you the treatment system MYOSA, and we focus mainly on the MYOSA for kids. But if you deal with adults, we have the same treatment system for adults as well. And so MYOSA for adults, I will get to that in a moment. But MYOSA for children from the ages of 3 to 15, which is a rough indication. 3-year-olds are more difficult to treat because cooperation is a big part of our treatment, and the 3-year-olds simply sometimes cannot cooperate because they're too young. And so then it's best to wait until you do get the cooperation, because the only thing that you can do with your therapy is explain to the children how they can solve the problem, but they need to do it themselves. And so we cannot do it for them. And so it is up to you to use every type of tool that you can, because most children would like to be done with the treatment between 1 to 2 years max. So we don't have years to treat these issues. And so the time that they actually spend with you for their treatment, you use everything that you can and have to get the problem solved. And so for children ages 3 to 15, with the most beautiful age between 6 and 10-year-old, that is with a lot of growth potential still in that child. The only thing that you do is that you create a situation where everything can grow according to plan. And so with incorrect breathing and incorrect swallowing, you use the MYOSA for kids. We have them in 3 sizes, small, medium, and large. And the one that you use is the one that fits. It is that simple. The breathing tests will determine which one you will use. If you will use the KS1, the MYOSA for kids stage 1, or the MYOSA for kids stage 2. When the breathing tests show that mouth breathing is a big problem, then you start with stage 1. And that is just to get the children from mouth breathing to nasal breathing in a more friendly way, because with the KS1, the children are still able to breathe through their mouths. So at night, when they wear the appliance while sleeping and their mouths fall open, they can still breathe through the appliance. And so it's not that difficult for the children. When the breathing tests show that mouth breathing is still a problem, but not that severe, you can use the stage 2 appliance, and this appliance does not allow for any mouth breathing. And so when you start your treatment with a child with a severe mouth breathing problem, you start with a stage 1. And further along in treatment, when the breathing tests tell you that the child's breathing has improved, then you can move on to the stage 2 appliance. And so that is a treatment goal in itself, for children to go from stage 1 to stage 2. And
Niles,
so,
we have only 10 minutes, so
yep, we're gonna go through. This is a really important slide because I was asked to emphasize the role of the functional specialist compared to the dentist, orthodontist, and how you can work together with the dentist. I mentioned follow, function, form, and form follows function. It is quite simple. When you're dealing with a child with a malocclusion, with a really narrow upper arch, one of the first things you do with the appliance as well is to get the tongue up against the roof of the mouth. When we're not eating, drinking, or talking, the tongue should rest up against the palate. But if the palate is that narrow that the tongue does not fit, then you can seek out dental practitioners to help out. Sometimes we need to help nature a bit, and so we have to provide room for the tongue. And so that is a possible cooperation between you and the dental professional. But another one is that dentists can refer patients to you, the functional specialist, because they see the malocclusion and they want to do something about it. But according to the age, orthodontics is not a possibility just yet because the children are simply too young. Then you, as the functional specialist, you treat function first. And when you've corrected function, incorrect swallowing and incorrect breathing, then whatever is left malocclusion-wise, that is something that the dental professional can pick up from that point. And so the slide you see now is that when you have your patient or your client wearing the stage 2 appliance from MYOSA, if the dental professional wants to continue that treatment and have the child go into a myofunctional orthodontic treatment, they can easily go further with the treatment. And so you have achieved your treatment goals. The dental professional picks it up from that point and then offers a myofunctional orthodontic treatment, where we see with MyoBrace that is where the treatment starts. I will show you this. What you, as a myofunctional therapist or SLP, can use is the activities program that we've developed, the MYOSA Fast Track activities program, and that allows you to treat the functional problems in a fun way, because we are dealing with 6 to 10-year-olds, mostly. And so we have to make it fun for them. And so it's fun for you and fun for the child as well. And so it doesn't feel like a standard, typical treatment. And so you can make it fun. And so we have multiple appliances that can help out. So, for example, this is a TLP, a tongue and lip exercise appliance. If we would like that orbicularis oris, that lip muscle, to be stronger, because if it's not strong enough, you can never have a proper lip seal, then this is a silicone appliance that you can use for activities to help out, to get that lip muscle stronger. And this is an overview of the appliances that we have in that activities range. And so we have a lip trainer as well. Are you familiar with the twine and the button exercise? Of course you do.
yes, they are.
The lip trainer is our take on that technique. And so it's a silicone version, and this allows you to actually address the entire orbicularis. And it actually looks more fun as well. We have them in blue and in pink. Yay! I can already see the children smiling. This is something, this entire program, activities program, with the use of these appliances, is to make it more fun for children and perhaps for the practitioner as well, but to get proper improvement in a fun and a more quick way. Because again, we don't have that much time to begin with. Children, especially the younger ones, don't allow you to treat for a year and a half. And so what we say, when you have the children in your practice, do whatever it is that you need to do and use whatever it is that you would like to use to get to the end of your treatment goals as fast as you can in a fun way. And so, considering the time, are there any pressing questions?
Someone has a question?
Yes.
I'm asking. I unmute. I gotta unmute everybody.
Can I ask a question?
Of course.
Thank you, Naz, for this wonderful presentation. I'm also a speech language pathologist, and I'm working a lot with myofunctional for both children and adolescents. What do you think about MYOTALEA?
Oh, that is a really
good one. You know, press the lips together. I typically recommend them at night.
We have no official opinion on the use of lip tape or MYOTALEA, but it is a tool, the same as the lip trainer, that you can use to get to where you want to be. It is never a solution, and so you can't use it for a long period of time, because what needs to happen as well is that during the day you need to train that lip muscle to get stronger, so that eventually you don't need the MYOTALEA anymore. But your nose is designed to breathe through, and so there is no problem whatsoever to use MYOTALEA.
Nancy, I have a question here.
Yeah.
On the chat. If you can explain how the MYOSA works, means like how does it help to transform the mouth breathing to the nasal breathing?
Yes. When you use the MYOSA, stage 1 or stage 2, that's the same. You put it in your mouth, you close your lips, and you press your tongue up against the tongue tag. The tongue tag is situated on the palate, and it points directly to the spot where the tip of your tongue needs to rest when you're not eating, drinking, or talking. And you wear the appliance for 1 hour during the day. And so when you wear it and you have your lips together, you are already training your lip muscle to get stronger. You already are working on strengthening the tongue muscles. And all the while, you breathe through your nose. And that's it with functional correction, is that when you keep it on long enough, when you keep doing it for long enough, it becomes a habit. It becomes second nature. And so the treatment with MYOSA appliances is you wear the appliance for 1 hour during the day with your lips together, tongue resting up against the palate, and swallow when you have to. And you wear it at night as well. At night is to prevent worse. During the day, that is the solution.
They have another questions. What are the solution or treatment offered, especially with overjet, while the patient has no problem with nose breathing?
Yeah. An overjet situation, it depends on how large the overjet is, but all our appliances are in what we call a class 1 front. You disconnected the mic there. Can you hear
No,
me?
again, because
Gotcha.
I heard baby crying, so I wanted to mute everybody.
Gotcha. When you wear the appliance, upper and lower teeth, they will be put in a class 1 anterior offset. And so when you are dealing with an overjet of 10 millimeters or larger, then you need to think about what we do is that it still fits, but we take it more slow, because the lower jaw has to come forward all that way. And so it is important that you do not go too fast, because we are dealing with patient ourselves with overjets of 17, 18 millimeters. And the muscles around your TM joint, they need to, you need to exercise with them first. So what we do then, when an overjet is too large, then we tell them to wear the appliance 5 minutes today, 10 minutes tomorrow, and so on, until you get to that 1 hour a day. And so we actually give our patients a 4-week period to exercise with the appliance to get to that 1 hour a day. It is not doable to have your children wear the appliance straight out of the box for 1 hour straight. That is too much. And so a large overjet situation is not a problem, but you need to take it slow. And that is the solution to that.
I have another question.
Mm-hmm.
Is the machine adjust the lips and the tongue to the correct position, or the child need to do it consciously? It seems like the lips are a little bit open. There's no touch between them with the MYOSA, don't it? Question mark.
Yeah. When you wear the appliance, when you have it in your mouth, you consciously close your lips. You consciously put your tongue on that tongue tag. That is it with conscious behavior. If you do that, if you practice on a regular basis, and so that is why we have the appliance worn every day for 1 hour straight, plus while sleeping, that conscious behavior will become second nature. And so you will get to the point where you do not think about it anymore, but you keep your lips together, for example. But that can only work if your lip muscles are strong. Lip muscle is strong. And so you do need to consciously close your lips over the appliance each and every day. And this is why the cooperation of parents is so important as well, is that it's not just a plaything for the children so they can leave the child alone for an hour. No, they need to be present. And so when they see the appliance in their mouths, but they have their lips open, they need to address that. They need to tell the child to close their lips. So at first, it's definitely a conscious behavior. So they need to tell themselves to close their lips and have their tongue pressing up against the tongue tag. After a while, with the strengthening of the oral muscles, it will become a new habit. And so
because it's connected to the brain. The brain is connected to, everything is connected.
Really good. Yeah.
Yes. Another question, anyone?
Mm-hmm.
Okay, so now I want to, I have another question. The difference between MyoBrace and MYOTALEA.
The difference between MyoBrace and MYOTALEA, that is a really good question. MyoBrace is a treatment system for dental practitioners. It is used to support a myofunctional orthodontic treatment.
It's only for doctors and orthodontics.
Yes.
Yes.
And MYOTALEA is an exercise appliance. And so MYOTALEA appliances, let me just show you one here.
This
right here. The MYOTALEA is a range of products that we use to do exercises with. And so a lip trainer, where we use it to strengthen our lip muscle, is part of the MYOTALEA range. And so
the MYO2 is part of the MYOTALEA. The TLJ is part. All of these are part of the MYOTALEA range.
Yes, exercise appliances.
Exercise for speech therapists.
Definitely.
Okay.
Any other questions?
Anyone? Now is your chance. He's here.
I'm here.
Ask.
I prepared for you.
I have a question. One question.
Yeah.
So if the orthodontist is recommending the patient to use the MYO brace, does he use it alone at home, or does an SLP or myofunctional therapist can work with it with the patient?
Definitely, they can work with it. So if your patient already has a MYO brace from an orthodontist or dentist, then you as a functional specialist, you can do your functional therapy with the support of that MYO brace appliance, and it works the same as the MYOSA appliance because they are the same. They just have a different name to distinct the two. But MYOSA and MYO brace are just tools for the practitioner to use to support that treatment, whether it is an orthodontic treatment or a myofunctional treatment. That doesn't matter. So the speech language therapists and the myofunctional therapists, they can support
with exercises
the appliance given to them by the orthodontist or the dentist. Yeah. Does that answer the question?
Yes, thank you. I can also recommend the patient to go to see an orthodontist that will recommend it and then come back to me, right?
Definitely. Yes.
Okay. Someone asked here, is any patient has his own כלים? מה זה? כלים? מי שאלה זאת? האם יש לכל מטופל כלים משלו? I don't know what does it mean. Can you explain about the MYO2? I have a question. The MYO2.
Yes, I can. The MYO2 is an appliance that you use when the children are too young to be treated. Every treatment and therapy out there will only work if you have the cooperation of the client or the patient. But some children, for example, a 3-year-old, where you see that functionally it's not going according to plan, when you see an incorrect swallowing pattern, which is definitely something that you need to correct, but a 3-year-old can't cooperate with your therapy or treatment. And so you do need to do something, but they're still too young for complete therapy. And so that is what the MYO2 is for. So the children who are too young, or you as a therapist would like to wean the patient off of the pacifier. Pacifiers are no good. So you need to get them out of the
way.
Exactly. And so you can use the MYO2 to do that. Thumb sucking, for example, you can use the MYO2 to see if we can stop the thumb sucking. But it is an appliance for young children to wear without any treatment
plan
to go along with the appliance, because simply they're too young. So this is something that you give to young children when they're just too young for treatment.
It's in order to start the brain to understand that it's going to the next phase. This is for young children. Thank you very much for sorry for leaving the meeting. Okay, thank you.
שלומית, רגע, שלומית.
Yes.
יש אחר מטופלת שלי, מי שרוצה להישאר, שהיא תסביר על החוויה שלה מהצד של המטופל.
Okay, we have here a client. She's 12 years old. She's here with us in the Zoom, and she's going to talk about her point of view. She is a patient,
experience.
okay? She will
Yeah.
speak in Hebrew and then I'll translate.
Good.
תום?
תום. שנייה.
היי.
היי תום, מה
היי
שלומך?
תום.
היי.
תום, את מדליקה מצלמה?
כן.
יופי, הנה תום שלנו.
היי.
תום, את יודעת אנגלית?
לא כל כך הרבה, אני לא בטוחה שאני אצליח כאילו להסביר את זה.
אוקיי, בסדר, טוב. אז את עכשיו בת כמה? בת 12.
12.
אוקיי, וכמה זמן את, מתי התחלת ללבוש את המיוברייס?
נראה לי שנה וחצי.
אוקיי. עכשיו את רוצה לספר מה היה לך, איך זה היה לך, להתחיל עם זה? היה לך קל? מה היה
בהתחלה היה לי לא כל כך נוח, כי כאילו לא הייתי רגילה לזה, ולא ידעתי איך כאילו בדיוק לשים את זה, וכאילו לא היה לי כזה נוח לישון עם זה, אבל אחר כך, אחרי כמה זמן שמתרגלים לזה, אז כאילו קשה כבר לא לישון עם זה ספציפית.
מה את אומרת? עכשיו כאילו קשה לך לישון בלי זה?
כן.
אוקיי. תומי מטופלת שלי כבר מזמן, הרבה זמן לא ראיתי אותה. אוקיי. עכשיו, איך הרגשת את ההשפעה של זה על השיניים שלך?
בהתחלה כאילו, זה כאילו השיניים שלי היו ממש, השיניים הקדמיות היו ממש עקומות והיו ממש על הפתח של הפה, אבל אחרי כמה זמן זה כאילו השתנה והם נכנסו יותר לתוך הפה, ואז יכולתי כאילו לסגור אותם שיהיה לי יותר נוח, וכאילו ראיתי כאילו את ההשתנות יחסית מהר, כאילו שזה השתנה יחסית מהר.
תום, את מרשה שאני אראה את התמונות שלך איך זה היה בהתחלה?
כן.
אוקיי, אז אני צריכה לעשות, אני יכולה לעשות שיתוף מסך?
אני חושבת, רגע. מה נעשה? רגע. איפה את? מיכל. רגע. make host. yes.
אוקיי, אז הנה, רגע, סקרין. הנה השיניים של תום החמודה.
רגע, Niles, can you share your screen? Unshare? Yes. This is Tom.
אוקיי, זה השיניים שהיו לתום בהתחלה.
Before.
את זוכרת, תום?
כן.
או ששכחת כבר?
כאילו חצי.
אחר כך כבר זה לפני BWS. זה לפני BWS.
זה
עכשיו...
כאילו K1?
כן, זה K1. אחר כך היא עשתה... את רוצה לספר על המרחיב שעשית? על המרחיב לסת?
כן, אז...
מה שראיתם היה ללסת מאוד צרה משני הכיוונים, משני הצדדים, אז היה לה קשה לשים את הלשון למעלה. אז מה שעשינו, עשינו לה מרחיב לסת מיוחד, שהיא יכולה לשים את הלשון גם למעלה, נכון?
כן, כאילו הלשון שלי לרוב הייתה או כזה מקדימה, או פשוט כאילו למעלה.
רגע, ועכשיו, איפה הלשון שלך הייתה אז ואיפה היא עכשיו?
פעם היא הייתה או כאילו שכבה למטה, או מתחפה קדימה, ועכשיו היא כאילו יותר או למעלה, או קצת כאילו באמצע איפשהו, כאילו סתם יושבת שם.
אוקיי, את עושה אגב את התרגילים? את ממשיכה לעשות תרגילים?
את החלק של הנשימה כן, וזהו.
החלק של הנשימה זה חלק שעושים אותו לאורך כל התוכנית. התרגילים של הנשימה זה תרגילים שמתרגלים אותם בלי להפסיק. אוקיי, אז את עדיין עושה את התרגילים של הנשימה.
כן.
מה בתרגילים של הנשימה את עושה?
לוקחת חפץ כלשהו, סותמת את הפה ואז בודקת כאילו ושם אותו על הבטן ואז כאילו הוא צריך כזה לעלות ולרדת.
אוקיי, הבנתי, נשימות מהבטן, היא מתכוונת שהיא מתרגלת נשימות דרך הבטן. מה עוד רציתי לשאול אותך? היה לך משהו כואב, לא נוח, מציק או משהו?
בהתחלה כאילו היה לי לא נוח, היה כזה משהו שאמור להחזיק את הלשון ולא כל כך הצלחתי להסתדר עם זה, אבל כאילו אחרי כמה זמן כבר התרגלתי לזה ואז כאילו שמתי את הלשון שם, כאילו יש
אוקיי, את רוצה להראות את השיניים שלך עכשיו?
לא יודעת, כאילו יש תמונות אמא שלי שלך.
אוקיי, רגע בוא נראה. היא עוד לא סיימה את הטיפול, אבל בואו נראה שנייה.
אולי גם את המרחיב חייך שנראה אותו איך הוא נראה.
המרחיב, את יכולה לכתוב בגוגל BWS.
כן, BWS זה המרחיב של MYOBRACE.
כן, שנייה, אני עכשיו מורידה את התמונה שלה. טוב, תמונה קצת חמודה. בוא נראה, אין לך את המרחיב עכשיו, נכון? כבר הורדנו אותו.
לא, עכשיו הורדנו.
רגע, הנה השיניים שלה עכשיו. אני חושבת שהיא צריכה עוד פעם לשים, את עוד פעם תצטרכי לשים את המרחיב, אבל התמונה פה לא כל כך טובה, כי לא רואים את הצדדים, לא רואים שזה באמת סידר את הקרוס בייט משני הצדדים, וגם תום, פה את תצטרכי לעקור את השן הזאת, את יודעת. את תבואי לנו ונעקור אותה.
טוב, אז זה הבדל גדול בין מה שהיה למה שעכשיו.
אם מישהו רוצה לשאול שאלה?
כן, אז אם מישהו רוצה לשאול שאלה בעברית, אז
אולי
מיכל
תראי לנו
פה.
רגע את השיניים בהתחלה, כי זה היה מאוד מהיר.
אוקיי.
תראי להם the start and the end.
זהו, שעוד לא סיימה.
כן, היא לא סיימה, היא בתהליך, אבל תראי להם איך היא התחילה.
הנה, ככה היא התחילה.
This is the beginning of the phase, the beginning of Tom treatment, and show them.
עכשיו היא עדיין לא סיימה, כי היא עדיין...
She hasn't finished yet her treatment.
אבל מבחינת התפקוד, שזה הכי חשוב,
כן, שזה המטרה שלנו.
היא סיימה, בדיוק. היא הייתה נושמת פה, היא הייתה נושמת כל הזמן מהפה, נשימה כרונית מהפה, והיא עברה להיות נושמת אף, והשפתיים שלה סגורות במנוחה, והן סגורות במאמץ או בקלות. טוב, אני לא שומעים אותך.
עכשיו יותר כאילו בקלות, אבל פעם כאילו היה לי ממש קשה לנשום דרך האף.
אוקיי, עכשיו תום, את ממליצה להשתמש במיוברס לילדים אחרים?
כאילו כן, אולי בהתחלה זה יהיה לא כזה נוח או מציק, אבל כאילו זה כאילו ממש עוזר גם לנשום מהאף וגם כאילו עוזר לשיניים כאילו להיות יותר ישרות.
לוקח זמן להתרגל.
טוב, תום, תודה רבה. תודה.
תודה.
ביי.
טוב, אז גייז, מי שנשאר פה, ומי שהיה, אז יש לכם מבצע 1+1 לרכישה באתר שלנו. אז מי שמעוניין, אני שולחת לינק פה לאתר. אתם יכולים לרכוש את המוצרים. וזהו, שמחתי מאוד. אתם צריכים כמובן להתחבר לאתר ולהיכנס.
אפשר יהיה לשלוח את הלינק הזה באותה קבוצת, באותו וואטסאפ ששלחתם את ה...
לינק לאתר?
כן, זה יהיה לנו נוח.
כן, זה מאוד נוח.
אוקיי, אז אני אשלח לכם בקבוצה גם, ואני שולחת לכם גם פה, אם זה יעשה לי סטנד.
עכשיו, את ה-BWS כתבתי בגוגל הרגע, וזה מצא סתם איזה סינדרום.
אז תכתוב BWS Expander.
BWS.
היי מיכל, מה קורה?
היי, מה נשמע?
דבש. Expander.
BWS Expander. Nice, I want to thank you very much
Oh,
Thank you.
you don't
Thank
need me
you.
for this case.
אה,
There are no questions about this case.
זה משהו שצריך אורתודנט בשבילו,
מה?
את האקספנדר הזה.
כן, כן, זה
כן,
רופא שיניים
רופא
צריך לעשות את
שיניים.
זה.
אוקיי, סבבה. בסדר.
איך אני...
כן.
זה? אז תודה רבה לכולם, והנה אני שולחת לכם לינק לאתר, ומי שרוצה, אני אשלח לכם את זה גם בוואטסאפ שלי, של הטלפון, תכף אני אשלח לכולם. פשוט צריך להתחבר לאתר, מי שמעוניין, מי שצריך עוד חומרים, קטלוגים, ברושורים, חוברות תרגילים, לראות סרטונים של התרגילים, כל מידע שאתם צריכים, אז יש לכם את הוואטסאפ שלי, כי שלחתי לכולכם וואטסאפ, ואתם ממש מוזמנים, אני אשלח לכם גם לינקים לאתר, יש לנו גם אתר מידע, גם אתר לקנייה, זהו, שמחתי מאוד, תודה רבה שהשתתפתם. סדנה הבאה יהיה לנו עם מיכל, כנראה באפריל אנחנו נעשה סדנה יותר על התרגילים ויותר משהו קצת יותר ממוקד, ספציפית. We want to thank you Nias very much for your cooperation. ויהיה לנו עוד סדנאות כמובן שאני אעדכן אתכם, כולכם פה ברשימה שלי. וזהו, מיכל תודה רבה, תום תודה רבה.
בבקשה.
Nice. Thank you and
You're welcome.
thank you very much.
Nice. Thank you very much, מיכל. Thank you, שלומי.
Thank you. Bye bye everybody.
Bye bye.
ביי. טוב.